All right. Kathy, any reason you see that I shouldn't get us started here?
No, go right ahead.
Okay. All right. Welcome, everyone. Thank you for joining us. This is CSH's Corporate for Supportive Housing's continuing series around H.R.1 implementation. H.R.1 is the law signed by the president the last year, has a lot of implications for supportive housing, affordable housing, homelessness field, et cetera, but particularly around Medicaid. So we are focused on Medicaid in this, and this is the first session that we're being using under the CSH's new brand, the National Center for Housing and Health, powered by CSH, but very much a partnership. And we are looking for more partners. So if you're interested in learning more about the center, next slide, please. Note to just our participants, we don't allow screen recordings or uses of the image. You want to use any of these materials, happy to talk about that. There's an email there as well. And the associated content, materials, presentation are the property of CSH. So thank you all for this. And this is all part of our new National Center for Health and Housing. As I said, my name is Marcella McGuire. I lead CSH's efforts around health and housing nationwide, and we are grateful to have you all with us today. So next slide, please. Just a little bit about the center, this National Center for Housing and Health. This launched last month. It's an innovative resource dedicated to advancing the alignment between systems, particularly between affordable housing, broadly defined, and the healthcare sector. This health center brings together innovations, models, practical strategies, policy. Lots of new resources there. New resource up today around hospitals invest in housing and build housing and create housing, and how hospitals can get engaged in the work around affordable housing in their communities. Visit us at the center website there, and there is also contact and questions information there if you want to hear more about the center. So next slide, please. We are here to talk about, as I said, about H.R.1, particularly about Medicaid and the many barriers that H.R.1 creates in order to help people keep their insurance coverage on. From the supportive housing lens, we think about as Medicaid as a key resource that pays for what we in the housing field may call supportive services. We see supportive housing as a three-legged stool. If you've been on a CSH webinar, you've seen this. You've seen this graphic before. Supportive housing is braiding funding between capital, what it takes to build the building, operating, what it takes to keep the program on the housing affordable for people with extremely low incomes, and then Medicaid, what Medicaid commonly refers to as services. But what's critical for the housing field to understand is without health insurance coverage, services are significantly more difficult, if not impossible, to access. Without Medicaid coverage, people lose access to their doctors, they lose access to their medications, they lose access to in-home services, they lose access to so many things that mean a life in the community for people with disabilities and other challenges. So our presenters here are going to talk about insurance, they're going to talk about Medicaid, but remember that the link between what we in the housing field would call services and insurance coverage is really a close to one-to-one link. So we're grateful for our presenters today to join us and explain to us both the challenges that people are going to face in the future, mostly starting in 2027, in accessing that insurance coverage and what it is you can do about it. So next slide, please. And so with this, I believe I turn it over to Farah.
Yes, hello everybody. My name is Farah Urzuki and I use she, her pronouns, and I'm a senior policy analyst at the Center on Budget and Policy Priorities. So I'll be starting by just kicking off and telling you all a little bit about the organization that I work for, and then we'll get into the webinar. So if we go ahead into the next slide. So, like I said, I'm with the Center on Budget and Policy Priorities. We are a nonpartisan research and policy institute. We focus on a variety of policy areas with a focus on advancing economic justice and equity. Our work spans healthcare, food assistance, housing and income security, budget and tax policy, as well as policy implementation. So not just analyzing and promoting policies themselves, but also on the ground work on implementing policies that are enacted. We also have founded and to date coordinate what's called the State Priorities Partnership, which is a network of policy and advocacy organizations across the country that span over 40 states, including Puerto Rico and DC. So I will go ahead and pass it over to Alicia to talk about NHELP.
Great.
Thank you, Farah. Hi, everyone. My name is Alicia Emanuel. I use she, her pronouns, and I am the Eligibility and Enrollment Practice Area Director at the National Health Law Program, or what we call NHELP. My colleague, Chandra Hartley, is also here with me today. If you could skip to the next slide, please. Thanks. So a little bit about our organization and Help. We are a national nonprofit committed to improving healthcare access, equity, and quality for low income and underserved individuals and families. We have federal, state, and local partners in 50 states, DC, and Puerto Rico. And we work with poverty and legal aid advocates. We also have a network of health called the Health Law Partnerships, which you can learn more about at the link on the slide. And we also have a strong network with disability rights advocates and sexual and reproductive health advocates across the country. Our organization is broken up into different strategy and practice areas, and you can learn more about our organization at our website. Next slide, please. Really quickly, we just wanted to touch on NHELP's equity stance. Our work is driven by our belief that health equity is achieved when a person's characteristics and circumstances do not predict their health outcomes. You can learn more about our equity stance in the link at the bottom of the slide. And now I'm going to pass the mic to my colleague, Chandra.
Okay, great. Thank you, Alicia. Hello, everybody. So I am going to walk us through our agenda for today's presentation. So we're going to start on the next slide with our learning objectives. From there, we will get, oh, I'm sorry, can you go back? Sorry. From there, thank you. We will get to the substance of address verifications. We'll talk about what the current policy is surrounding that, the new requirements that H.R.1 imposes, the impact on folks experiencing homelessness, housing instability, and in HUD-assisted housing, and some best practices that advocates can push for. And then we'll get into some of the other sort of red tape and restrictions in HR1. Um, so that's work requirements, the more frequent eligibility redeterminations, and changes and limitations on retroactive eligibility. And then we will end with some advocacy tips. Next slide, please. So our learning objectives for today are to understand the new Medicaid address verification requirements in the 2025 reconciliation law, or OBA or HR1. We will review additional eligibility restrictions and red tape concerns and understand their impact on people experiencing homelessness, housing instability, and affordable and supportive housing residents. And then we will explore advocacy ideas to minimize the risk of erroneous coverage loss for this population. Next slide, please. So I'm going to start with some background on where all of this address verification stuff comes from. And then we will get into HR1's changes and the impacts that we anticipate seeing. So, the Public Assistance Reporting Information System, or PARIS, is a database operated by the Administration for Children and Families, or ACF, and it collects very specific data. So, one way that states use PARIS is as an income data source for certain limited types of income data, such as VA benefits and federal retirement payments. But Paris's most prominent application, and the one that is the most relevant to us today, is to check for duplicate interstate enrollment in safety net programs such as Medicaid. So, what does duplicate interstate enrollment mean? Basically, what it boils down to is that you can't be enrolled in Medicaid in more than one state at the same time. So, states use Paris to check for enrollees in their state who might be enrolled in Medicaid in another state at the same time, and then they take whatever case action the state deems appropriate. So this could be as much as closing the person's case or pursuing recovery of any benefits that may have been, incorrectly paid. Under current law, it is up to the state to decide how they want to proceed once duplicate enrollment is detected. Now, states have technically been required to use Paris since 2009, but even so, as of now, they don't generally make like significant use of Paris. For example, states have reported that they don't submit complete or accurate information to Paris to find their matches because of technology issues and limited staff capacity. And even successful Paris matches, which are those that actually identify somebody who is enrolled in more than one state, often go unpursued by states because it just isn't cost effective or resource efficient for them to pursue that. Nevertheless, though, H.R.1 imposes new requirements associated with Paris use and address verification. So, beginning January 1st, 2027, states must perform regular Paris checks to identify duplicate interstate enrollment, although as of now, we still have not heard what regular means. Currently, states have to submit information to Paris to facilitate the matching process on a quarterly basis. So it's not clear if HR1 is going to maintain that requirement or if it's going to require the matches be performed more frequently. And then it's also not clear at this point if HHS is going to enforce the Paris match requirements more strongly than they currently do. Um, Either way, beginning October 1st, 2029, states are going to have to check for duplicate interstate enrollment on a monthly basis. So that's going to be up from quarterly, where we're currently at. And then also by October 1st, 2029, HHS is supposed to implement a new system for these checks, but it still isn't clear at this point whether that system is going to replace Paris or whether states are going to get to decide what system they use. And then one last really important thing to note, unlike the other red tape changes we're going to discuss today, which are work requirements, 6-month redeterminations, and limits on retroactive eligibility, this change applies uniformly across all Medicaid eligibility groups. Next slide, please. So, like all of the changes that HR1 makes to Medicaid eligibility and enrollment, this increased address verification puts folks at much greater risk of erroneous coverage loss. As a threshold matter, every time an enrollee's eligibility is reviewed, whether that is an address verification or some review of another eligibility factor, that interaction or touch creates a potential failure point which puts that enrollee at risk of erroneous coverage loss. So, to put a finer point on it, the more frequently a system touches or interacts with an enrollee, the more likely that enrollee is to erroneously lose coverage. And this can occur for a variety of reasons. Some examples are, for instance, an enrollee might have moved or otherwise not received mail at the address that the state agency has on file for them, which means that they aren't going to see a communication from the state agency concerning the eligibility review. The time period that the state offers for the enrollee to respond to a request for information and demonstrate their continued eligibility might be prohibitively short. In some states, it's as short as 10 days, which can be, really tough for folks to manage. Um, and then another example is income fluctuations that are common among folks with lower incomes might mean that in states checking income more frequently, an enrollee could be disqualified for excess income in one month, but then qualify again in another month, despite the fact that their total income for the year is below the Medicaid eligibility threshold. Um, and so these are examples of how increased administrative burden, such as through more frequent eligibility verification tasks, makes it harder for eligible people to retain their coverage. And so because of that, this increased burden and these increased verifications are associated with what's called churn, which is when eligible enrollees lose and regain Medicaid coverage within a short period of time, sometimes repeatedly. Typically, this is for procedural reasons, not that the individual was actually determined ineligible for Medicaid. And really important is that these effects can be compounded for groups already experiencing existing disparities, such as people experiencing homelessness, people with disabilities, and people of color. Um, oh no, did we lose the slides?
I think we are getting back to the spot. Kathy, looks
Okay,
like,
I'm gonna go
sorry,
ahead and
Chandra. No,
no,
keep
that's all
going.
right.
She
I'll go.
wasn't here. Further along. Keep going, keep going, keep
There
going.
we are. No,
Where?
go
Work
back one.
requirements.
There we go.
There, there. Thanks.
So the good news is, though, there are still interventions that advocates can push for to mitigate the harm of this policy. So one of the things we think is particularly important and what I'm going to focus on right here is maximum implementation of the 2024 eligibility and enrollment final rule. So this was the second part of a two-part federal rule that would have made significant streamlining changes to the process of enrolling in Medicaid and other related programs, and would have also improved coverage retention for folks already on the program. H.R.1 put a partial moratoria on the rule, which means that HHS at the federal level can't enforce the parts that are blocked. But a lot of the rules, protections, and streamlining changes are still in effect. Remember, this is just a partial moratoria. They did not all get blocked. And more importantly, states can still adopt most of those protections and streamlining provisions as a matter of state policy, even if they're not enshrined in federal regulations. So I'm not going to get too into the weeds on the rule today. We do have a link to a resource on this slide going over each individual provision of the rule and whether it's in effect and whether a state can implement it. Um, and for our purposes, I think it's most important to note that there are a variety of protections associated with address changes and returned mail that states can still implement, and they should if they haven't done so already. These protections will greatly simplify how states address these issues and will reduce the number of eligible individuals losing Medicaid coverage simply because of an issue, with their address or potential return mail. And now I am going to go to Alicia to talk about work requirements.
Great. Thank you, Chandra. So the second red tape issue we're going to talk about briefly is work requirements. As you may already be aware, as a result, next slide, please, Kathy. Thanks. Perfect. So, as a result of a law enacted by Congress in 2025, beginning January 1, 2027, states are required to implement work reporting requirements for certain individuals to get on and stay on Medicaid. Work requirements only apply to individuals who are eligible for Medicaid through what's called the Medicaid adult expansion population. These are individuals who are 19 to 64 years old. And to be clear, if individuals are eligible for Medicaid in a different category, like Medicaid based on disability, being a low-income parent, or people who are pregnant or postpartum, they are not subject to Medicaid work requirements. States, the asterisk there is because states are allowed to implement work requirements earlier with CMS approval, or they can obtain a good faith effort delay, but it's unlikely CMS will grant these. If individuals are subject to work requirements, they must either engage in work-related activities or be eligible for an exemption. Work requirements apply to people in Medicaid expansion states or partial expansion states. We will not get into the details of that today. All you need to know is that this applies to people in expansion populations in 43 states, including DC. Next slide, please. Okay, so let's dive in a bit more on how an individual meets the work reporting requirement. To meet the work reporting requirement, individuals must either engage in one or more activities for 80 hours per month. This could be met by engaging in work, volunteering, performing community service, and/or doing a job training program. Importantly, individuals can combine activities to meet this requirement. Another way to meet the requirement is to be enrolled in a part-time educational program. This could be a career, technical, or higher education program. Or individuals can meet the requirement by having income from any source of $580 per month. The $580 per month can be earned or unearned income, and individuals with seasonal work could average $580 per month over a 6-month period to meet this requirement. So for Medicaid applicants, states must require the individual subject to work requirements to meet this requirement for at least 1 month, but not more than 3 consecutive months prior to the month of application. And for enrollees, at a minimum, states must verify compliance every 6 months. Next slide, please. Okay, this slide is really just here for reference and emphasis. I mentioned this already, but there are certain individuals that are not subject to Medicaid work requirements. And now I'm going to popcorn it back over to Chandra to talk through some exemptions.
All right, great. Thank you, Alicia. Next slide, please. So, for work requirements, H.R.1 designates a lot of different groups of folks as specified excluded individuals. So this means that for folks in these groups, the work requirements don't apply to them as long as they remain specified excluded individuals. We do not have an exhaustive list of those groups on the slide because it is quite extensive. But some of these specified excluded individuals are former foster care children, certain American Indian or Alaska Native groups, parents, guardians, and caretaker relatives as defined in the RAISE Act, veterans with total rated disabilities. This is a big one, people who are medically frail or who have special medical needs, and people participating in drug or alcohol treatment. The medical exemption or the medically frail exclusion includes specifically people who are blind or disabled per the Social Security Act definition, people with substance use disorder, people with a disabling mental disorder, people with a physical, intellectual, or developmental disability that limits one or more activities of daily living, and people with a serious or complex medical condition. We're waiting for more guidance from CMS right now on some more details and parameters of those exemptions, but that is the broad list contained in the statutory text at this time. Now, another set of exemptions to be aware of are the short-term hardship exemptions. These are optional exemptions that states can adopt for folks in the following extenuating circumstances. So these are folks receiving care in a hospital, nursing facility, psychiatric facility, or other intensive care setting. Folks who are in a federally declared disaster area, folks who are living in a county with an unemployment rate higher than either 8% or 1.5 times the national unemployment rate. And then people who are or they have a dependent who is required to travel outside of their community for medical care for an extended period of time. Um, the good news is on these is that most states have indicated as of right now that they are going to adopt some or all of these short-term hardship exemptions, but we are still awaiting further details from CMS on how they're going to be operationalized. Some states have also indicated interest in working to exempt people experiencing homelessness or housing instability from the work requirements. But again, we're waiting to see what CMS says about that. It isn't clear as of now whether adding exemptions beyond the H.R.1 statutory text is going to be permissible. And so again, to that end, this information isn't exhaustive, and we do have some resources listed on the last slide that discuss work requirements and exclusions and exceptions more in depth. We are anticipating further guidance from CMS on work requirements, including exemptions, very soon, likely within the next few days. So we're keeping a close watch out for that one. And I will pass it back to Alicia.
Great. Thank you, Chandra. Okay, next slide, please. So where are we now? There are various challenges with the implementation of work requirements. H.R.1 provided less than 18 months from enactment to the go live date. And at this point in time, states are making really complex eligibility system changes. What history tells us is that increased programming errors happen when changes are implemented on a rapid timeline, and integrating new data sources and changing entire eligibility workflows in Medicaid eligibility systems are not small tasks. Simultaneously, as Chandra mentioned, states are awaiting further guidance from CMS. CMS is required to issue what's called an interim final rule, or IFR, by June 1 of 2026. We are waiting on pins and needles, and we'll know a lot more soon on finalized guidance and how that will impact relevant state policies and procedures. Additionally, states are required to engage in outreach at least 4 months before they implement Medicaid work requirements. And for some states, outreach notices need to go out by the end of June. But certainly it's difficult to land on both the scope and the details of outreach materials without this detailed guidance we need from CMS. I mentioned earlier that states are permitted to implement work requirements early with CMS approval, and right now, unfortunately, several states are on that path. So Nebraska implemented work requirements earlier this month on May 1st. Montana is slated to implement work requirements on July 1st. Iowa will begin work requirements on December 1st of this year, and Arkansas is proposing a soft implementation in 2026, although currently coverage loss will not begin until 2027. Next slide, please. So we wanted to take a bit of time to talk specifically about how you all can support people experiencing homelessness and housing instability with work requirements compliance. Excuse me. You all play a critical role during this time. Um, we know from some of our partnerships across the country that there are unique challenges that people experiencing homelessness and housing instability face. And we also recognize that some states are more willing than others to collaborate with advocates. A few key advocacy strategies, though, that may support this population include first and foremost, performing outreach and communication through multiple pathways, especially for those who are displaced, sending information um, multiple times through text, email, mail, and other modalities will help ensure that the word gets out there about work requirements and other red tape provisions. Advocates should also encourage states to collect data on housing status so that states can really evaluate the impact of work requirements on people experiencing homelessness. Um, Also, a best practice, state materials should be user tested by people experiencing homelessness and housing instability. And advocates should also encourage states to maximize use of data available to the state to prove people meet work requirements or the exemptions so that the burden is removed from individuals who are experiencing housing instability. Um, it will be a challenge both to acquire the paperwork needed and to get the paperwork needed to county offices, absent perhaps a cell phone, fax machines, use of a car. Um, and there's an additional resource at the bottom of the slide there for you. Next slide, please. Okay. All right. So this is a heavy one. So history tells us that work requirements don't increase employment. They do take coverage. The policy does take coverage away from eligible people and has the potential to lead to significant coverage loss. A recent study by the Urban Institute says that based on conservative estimates, 4.9 million people will lose coverage by 2028 due to work requirements alone. And one model shows up to 7 million people could lose coverage due to work requirements in 2028 alone. Some estimates are as high as 7 to 10 million people losing coverage when you account for the implementation of work requirements and more frequent eligibility checks. Researchers project that between 19% and 37% of people who already work will still lose Medicaid coverage, even if they meet work reporting requirements, simply because of the challenges they face documenting their work activity. And unfortunately, what we know is that although across the board, work requirement compliance will be challenging. It will be especially challenging and likely punitive for individuals with disabilities, people with chronic illness, individuals with limited English proficiency, for people experiencing homelessness, housing instability, or living in supportive housing, and individuals with seasonal or gig work, or who are self-employed, who are less likely to have paperwork and proofs. Okay. All right. I'm going to pause there and pass it to Farah.
Great, thanks. So if we go on to the next slide, just a couple more changes from HR1 that we'll be covering. So this next requirement is around more frequent eligibility checks. So currently, states are required to renew Medicaid coverage for individuals no more frequently than every 12 months. In H.R.1, that changes the frequency. So, H.R.1 includes a new requirement that adults specifically enrolled in Medicaid expansion, age 19 to 64, now have to renew their coverage every 6 months instead of every 12 months. So this change applies to a similar population that is covered in under work requirements with a couple of exceptions. So it does not apply to that list of folks that Alicia had gone over previously. So folks who are eligible for Medicaid as a low-income parent, pregnant or postpartum individuals, or folks enrolled in Medicaid based on a disability, as well as people in non-expansion states. The only group exempt, however, from more frequent renewals, so this is much more narrow than the exemptions for work requirements, is American Indian and Alaska Native individuals. So the remaining exemptions for work requirements do not apply under this provision for more frequent eligibility checks. So on to the next slide. So this change also goes into effect on January 1st of 2027, and this means that renewals initiated starting in January and onward will receive a 6-month eligibility period. So people currently enrolled in Medicaid are not going to now have a 6-month period. They'll still finish out their 12-month eligibility cycle, but once their coverage is up for renewal in 2027, they will receive a 6-month eligibility period. And of course, something to note here, and similar to what Chandra mentioned in general around red tape and more frequent interactions and touch points with the state Medicaid agency. The big thing to keep in mind here is that, and why this is going to cause coverage loss, is double the renewals means double the touch points with the state agency, oftentimes double the paperwork, which will all lead to a heightened likelihood of enrollees falling through the cracks and losing their Medicaid coverage. And for folks experiencing homelessness or housing instability, of course, they might not receive the paperwork requests, and the agency might not be able to reliably reach them. So, of course, this is going to have disproportionate impacts on those populations and likely lead to more coverage losses for procedural reasons rather than due to lack of eligibility or ineligibility. So, on to the next slide. The last change that we're going to cover is changes to retroactive coverage. So retroactive coverage is a policy that allows Medicaid to cover medical expenses that are incurred before an individual actually applies if the person is found eligible during those months. So let's say someone applies this month in May and they incurred costs in April. If they were eligible for Medicaid and were successfully enrolled, they'd be able to receive coverage, or Medicaid would be able to pay for those services that were incurred in April as well as March and February, if I have the months right there. So currently, retroactive coverage is 90 days for all enrollees, or individuals have 90 days of retroactive eligibility, which means that 3 months worth of expenses before they apply could be covered if they are found eligible. H.R.1 changes this. It places limits on retroactive coverage. So instead of 90 days for all populations, now Medicaid will only cover services in the 30 days prior to application for expansion adults, and then 60 days for all other Medicaid populations. So, of course, when you layer this on top of, the more frequent eligibility checks, on top of work requirements, folks can more easily fall through the cracks and lose their Medicaid coverage. But then with this change, if they are able to successfully re-enroll in Medicaid, there's a shorter period of time that they will be able to get coverage for those services and costs that were incurred in that period of time before they reapplied and were able to get re-enrolled in Medicaid. So, of course, this can result in more costs and more burden on individuals as well. So on to the next slide. This is just, a little bit of an overview on some support that, this audience can provide to people experiencing homelessness and housing instability through these changes. A lot is similar to the suggestions from Chandra and Alicia. So, in terms of supporting enrollees, making sure that their contact information is updated across multiple modalities. So, oftentimes I know we're talking here about like address changes and folks having variation in their addresses, but making sure that their phone numbers are up to date, their email and any other communication modalities are up to date, because oftentimes the agency might try to contact a person not just through mail, but also through other communication channels as well. So making sure that all of those are up to date. And then, like what's been mentioned already, making sure the state agency is updating their own materials to not only reflect the changes that are coming, but also to update to make sure that they are contacting enrollees rather via multiple modalities when their cases are up for renewal, and also ahead of when these changes are taking place, to make sure that people know that changes are coming, and encouraging them to make sure their information is up to date. And then lastly, making sure that, community organizations and other stakeholders that work with people experiencing homelessness and housing instability, making sure that those folks are informed of the changes to come, and supporting them with any outreach and communication materials to support enrollees through those changes. And once the changes happen, supporting them through, through the process of making sure that they can keep their Medicaid when that time comes. And so with that, I'm going to turn it back over to Chandra to close us out with some other suggestions and best practices.
Great, thank you, Farah. So yes, I'm just going to go ahead and bring us home. So some additional resources and sort of advocacy tips. There are a lot of state level resources that folks can connect and engage with in order to, ease implementation, protect impacted people, and fight against some of the worst harms of these policies. One important thing is engaging with your state's Medicaid advisory committees and beneficiary advisory councils, or MACBACs. That's an excellent way for impacted individuals to engage and share their lived experiences. Folks can also connect with state and local coalitions who are engaging in H.R.1 implementation work, and with local legal aid organizations to access assistance for impacted people. Next slide, please. And then here we have a collection of resources from NHELP and CBPP that we think are going to be particularly helpful as folks navigate these complicated issues. And then you can also find more from NHELP, and I'll put this in the chat in just a minute, on HR1 implementation at healthlaw.org/prepare, which is our post HR1 Medicaid and ACA defense landing page. Next slide, please. And that's it. This is just a slide with NHELP's contact information. And so I think we're going to go back to Marcella now for Q&A.
All right. Thank you. Thank you, everyone. Thank you, ladies. Such detailed information, such great links. Folks are asking, will they get the slides? Yes, I've dropped a link on the webinar. I'm sorry, I've dropped a link in the chat of where you can look at the grab the slides and materials. You can also see all of our other series in this session, etc. So yes, Chandra's putting the NHELP ACA defense leading page. So grateful for that as well. We did not have too many questions in the chat. What I will say is that one really helpful question that I want everybody to hear, Dara Weininger from CSH, she said participants need to, quote, prove enrollment in these activities. Can you speak to the proof that will be needed to be accepted? Alicia answered this one. We're waiting more CMS guidance on this. States should first be verifying with data readily available to them. That's a fancy Medicaid phrase called ex parte. today, meaning check the data systems. If I have, say, a mental illness, I may be in your data systems with a diagnosis. But we will see, and that is also very much a state by state choice, and it will have to be, I think, as our presenter said a couple of times today, be impacted by the CMS guidance that we're expecting in the next couple of days. Ladies, anything to add there?
I think you covered it.
Okay. Oh, cool, cool. Well, Alicia covered it, and I read her write up very well on that. Any other questions, folks? All right, Kathy's putting up the Kathy Vade, who's our administrative support here, is putting up the evaluation pool. So if folks can please click on that and give us your how are we doing here. I'm gonna hold for just a minute and see if there are any other questions. Feel free to put them in the Q&A. All right. So next slide, please. As we said, this is a part of an ongoing series. We did the evaluation. Thanks, Kathy. So next slide after that one. All right. We did the evaluation. I'm sorry. Next in this series, we are going to talk about SNAP, or the Supplemental Nutrition Program, the SNAP program you hear it, the food stamps program. This is going to be on June 17th, 3 to 4. There's a registration link. You can also find out more details about this on the HR1 page. We also know that food is medicine. People's access to food is going to be really critical to their health. And we know that already many state cutbacks from SNAP are already happening. So we're going to talk about that and learn more about how to support the people you serve there. So again, slides will be shared. Yep. Alicia's got her email in the chat. We've got contact info all throughout the slides, and just really appreciate those efforts. And please also be in the touch at the center if you've got more information you need, resources you need, how we can help. All right. Any last words, lady? We say goodbye and give these folks 12 minutes of their busy day back.
Thank you for joining, and just deep appreciation in advance for all the work you're going to do on the ground to help people enroll in and maintain their Medicaid coverage. These are big, scary changes, and it's really going to take a groundswell of folks to help keep coverage. So thank you, thank you.
And thank you to our presenters for their breadth and depth of knowledge on this and sharing that knowledge so easily and so simply. It's very complicated, and you make it seem as simple as possible. All right, so thank you all, everybody. Have a great afternoon.